Looking forward to our next speaker, who is Kim Tarr, a senior pharmacist here at Royal Brisbane and Women's Hospital in Queensland. She's had over 20 years experience, 20 years experience in really all aspects of infectious disease pharmacy. So we're going to hear about CoPAT, really, can we make oral antibiotic administration safer? And this is a pilot study she's going to tell us about.
Thank you, Ben, for trying to add 10 years onto my age. I haven't been practicing for 30 years. I'm sure you have, with your extensive knowledge in ID. But I'd like to, thank you for the invitation to speak tonight. I'm quite fortunate to present alongside Matt and Tony, who presented some excellent sessions. And thank you for setting the bar so high. I may not reach it, but I'll definitely try. Let's get the microphone quickly. I'm also quite fortunate to present something which Dr. Kate McCarthy gave a great lead into in her last presentation to this HIF OPAT Masterclass series, when she talked about earlier IV to oral switch using highly bioavailable oral antibiotics, or HBOAs, and I'm sure you all know what they are. So Kate's presentation provided an excellent summary of the literature supporting earlier IV to oral switch, including landmark papers such as the POET study and Oviva trial. So I won't cover these again. But then she introduced a pilot study, which we conducted to assess the benefits of a CoPAT service to safely facilitate earlier IV to oral switches for these indications. And so my presentation today will be focusing largely on the results of this pilot study. To quickly recap, Kate described the potential benefits from earlier IV to oral switch, particularly for serious infections such as bone and joint infections. But it's also worth noting that other infections such as TB or NTM have had longer-term evidence supporting the use of HBOAs, and even some antibiotics with high tissue or intracellular uptake, such as clofazimine and azithromycin. So we're also referring to these agents when we talk collectively about HBOAs in our study. But wait, there's more. Despite the obvious benefits of IV to oral switch, HBOAs are not without their problems. And this was seen in the Oviva trial, when nearly a third of patients in the oral antibiotic treatment arm developed at least one severe adverse event. And when we conducted a pre-study audit within our institution to see if there was a problem with HBOA prescribing, our results told a very similar tale. In that, at least 6 patients a week were being started on a HBOA, and this number was only increasing. And 16 patients required hospital readmission due to the severity of their adverse events. So there were some concerns that earlier switching of patients to HBOA for these severe infections may place them at greater risk due to reduced monitoring or health assessments, which they would have otherwise received if they were getting these IV antibiotics through community services such as HIF. And also, as routine outpatient clinics often can't accommodate the frequency of reviews required for HBOA prescribing, and may even occur weeks to months after starting therapy. So our aim was to pilot a monitoring service for patients on long courses of HBOAs in the community. And we hypothesised that providing structured monitoring and management of ADRs in a timely fashion with proactive medication education by a CoPAT monitoring service would allow earlier identification of an adverse drug event and community-based symptom management and or drug switch, therefore preventing patient morbidity and hospital admissions and allowing achievement of therapeutic goals. And we piloted this service as proof of concept. In the interest of time, I won't run through the methodology of the study, as Kate outlined this quite well in her presentation in this slide. But I did want to mention that CoPAT was not involved in the choice of the antibiotic regimen. We ensured the ID team had been involved and that the patient was on the most appropriate regimen for their infection. However, this didn't preclude the pharmacist from optimising therapy by assessing pharmacokinetic and pharmacodynamic parameters of the antibiotic regimen in the context of the patients. So reviewing for potential drug disease or drug-patient interactions and making recommendations to the treating team. So this new service commenced at a singular quaternary hospital in Brisbane, and this study reports the first 6 months of service. A total of 57 patients were referred to CoPAT during the study period. Of these, four patients were excluded for the reasons outlined there, and so 53 patients were enrolled into the program. In terms of the patient demographics, just over half were male with a median age of 57 years. Common infections were bone and joint, non-tuberculosis mycobacterium, so NTM, and mycotic infections. However, collectively, mycobacterial infections, so NTM, TB, and latent TB, accounted for over a third of HBOA indications. Most patients were prescribed one HBOA, and patients on 3 or more HBOAs had mycobacterial infections. The median patient time on CoPAT was 2 months, ranging anywhere from 3 to 24 weeks, although over half of patients had an intended or planned CoPAT duration of over 3 months, which was largely driven by treatment of mycobacterial and mycotic infections. And the median rate of referral to CoPAT was 2 patients per week, although we accepted up to 6 new patients a week. So these were the antibiotics which were prescribed on CoPAT. So the rifamycins were the most commonly prescribed, so a composite of rifampicin and rifabutin, which reflects the use of these drugs in both mycobacterial and bone and joint infections as part of combination therapy, followed by trimethoprim and sulfamethoxazole, or cotrimoxazole if you're from my generation, and azithromycin. And not surprisingly, the majority of HBOAs were for the treatment of mycobacterial and bone and joint infections. There were 81 surveillance monitoring tests facilitated by CoPAT, which can be seen there, with a mean rate of 1.5 per patient. So patients on average required around 1 to 2 surveillance monitoring tests for potential adverse reactions from their HBOA. The most required monitoring was for identified drug interactions, which was flagged in about a third of patients. Sub-analysis of these revealed azithromycin was the HBOA most associated with potential drug interactions, and 50% of the drug interaction risks were associated with QT prolongation and rhabdomyolysis. Other monitoring requirements included ECG monitoring for HBOAs, which prolong the QT intervals, such as clofazimine, peripheral neuropathy via lower limb sensory tests required for antibiotics, such as linezolid, isoniazid, fluconazole, therapeutic drug monitoring, or TDM, for drug toxicity and optimizing therapy. Most were for antifungals, some were for mycobacterial agents. Ophthalmology monitoring for drugs predisposing to optic neuritis, so tests such as Ishihara and Snellen chart, and surveillance audiometry for ototoxic drugs such as macrolides. And these were coordinated with the treating team or the patient's primary care providers. In terms of CoPAT activity, over the 6 months, a total of 327 phone reviews were conducted to monitor patients on their HBOA therapy. So a mean rate of 12 phone calls a week. And we were escalating on average, about 2 HBO-related issues a week to treating teams. A total of 132 interventions were made, so an average of 2.5, so around 2 to 3 interventions per patient. These are outlined in this table here and included mostly organising urgent pathology, so faxing and emailing pathology forms or calling patients to increase frequency of blood tests, often after flagged abnormal pathology such as hyperkalemia or TDM results. Other interventions included facilitating medication supplies for patients, organising monitoring protocols such as ECGs and audiometry testing, and recommending ancillary treatments such as prescribing antihistamines for allergic reactions. Most importantly, 11 HBOA therapy changes or drug manipulations were recommended and or implemented safely by CoPAT in the community. These included 5 antibiotic substitutions, 4 dose changes, and 2 treatment duration changes, all in response to adverse events. The graph also delineates between pharmacist versus nurse interventions. And although it looks like the pharmacist made more interventions, I promise I'm not being biased. It really just reflected the nature of the service, as the nurse largely carried out the operational tasks of the clinic, such as calling patients, organising monitoring tests, and then if anything abnormal flagged, she would then escalate to the pharmacist, who would then escalate to the treating team if required, thereby more often scoring the intervention for the pharmacist, when really every intervention was a team effort. And I just wanted to make that clear because my lovely OPAT HIT nurses are here in the audience. In terms of adverse events, a total of 29 were experienced. Of these, the most common were gastrointestinal and hematological side effects, such as anemia and neutropenia. 16 patients, so a third of the study population, experienced at least one severe adverse event while on CoPAT. In 75% of these cases, the severe adverse event led to cessation and/or antibiotic substitution of the HBOA, informing that most severe adverse events were attributed to the antibiotic. And 44% of these patients required hospital readmission for management of their severe adverse events. In about 70% of these cases, CoPAT was the patient's first contact with healthcare when the adverse event occurred, which was on average 5 days from symptom onset. And cotrimoxazole was the antibiotic most associated with severe adverse events, causing close to half of the cases. And on top of this, over half of patients who experienced a severe adverse event on cotrimoxazole required hospital admission for management. So it was clearly by far the HBOA which caused the most problems on CoPAT, and one that Tia and I kept a close eye on when initiated. In terms of cost analysis of the service, we did some preliminary costings. There were 19 patients who had serious infections conventionally managed with 4 to 6 weeks of IV antibiotics via home-based care such as HIT. We calculated that cumulatively, these patients spent 606 days on CoPAT, resulting in approximately 363 days of IV treatment saved. This was estimated to provide a cost savings of approximately $286,000 through home nursing visits saved, including, saved costs on one-off PIC insertions or central line insertions and antibiotic infusions. So minus labour costs, the 6-month of CoPAT pilot potentially saved an estimated total cost of around $200,000 or just over $100,000 per day. And our cost analysis was modelled similar to that conducted in this paper by Marks et al., which reported the potential cost savings from IV to oral switch in eligible OPAT patients at their centre following the OVIVA study criteria. In addition to this, CoPAT enabled 11 successful drug manipulations to occur in the community, thus potentially preventing 11 emergency department presentations and the potential costs associated with those. So at the end of the pilot, 60% of the 53 enrolled patients had been discharged from CoPAT. Of these discharged patients, just over half successfully completed CoPAT and achieved their therapeutic goals. Of the remaining patients that didn't, 22% were discharged as they developed at least one severe adverse event, which led to cessation of HBOA therapy. One patient required hospital readmission due to clinical progression of disease, so readmission rates were very low for treatment failure. And 4 patients were discharged from the service due to non-compliance with monitoring requirements. And just under half of enrolled patients were still on the service at close of the pilot. And how did the patients feel about the service? Well, results collated from satisfaction surveys were largely positive across the scope of questions asked, with most patients expressing they understood the expectations from the service and their antibiotic treatments, and that the CoPAT teams listened. And all patients felt comfortable with a telehealth appointment to discuss their medications. So key findings from our study were CoPAT enabled safe substitution of HBOAs for IV therapy for serious infections. So more than half of patients discharged from the service achieved their therapeutic goals. And this was enabled largely by standardised and close follow-up care provided by an integrated multidisciplinary team. So we detected severe adverse events in a third of our CoPAT patients, which is in line with the Aviva trial and speaks to the high-risk nature of these therapies and their need for close monitoring in the community, particularly as doses of HPOAs for severe infections are often higher and duration of therapy is longer in the order of weeks to months. So CoPAT was the first healthcare contact in 70% of severe adverse events, which was on average 5 days after symptom onset. Now, there's no granular data if early detection of adverse reactions makes a difference to hospital length of stay, but pragmatically, early detection would allow for prompt intervention and thus prevention of severe adverse sequelae. In terms of the 5-day timeline, this is a, so this is a byproduct of the CoPAT reviews being weekly and is something that can be improved on, but it's, it's worth noting that, I'll just pause that, but it's worth noting that we implemented the service during the peak of COVID and pandemic-related challenges did have an impact on the timelines for our service delivery. Despite this, among the patients who experienced a severe adverse event, 50% of these cases were safely managed in the community by CoPAT. So my next point is we conducted more than 300 CoPAT phone reviews, which replaced traditional face-to-face outpatient clinics. You could argue that these clinic reviews would have occurred anyway, irrespective of whether there was a CoPAT service or not. But the value out of CoPAT is that these 300 phone reviews freed up consultant and medical reviews for other or more complex cases, and thus improved clinic efficiency by freeing up appointments and preventing clinic waitlist blowouts. So there is a real role for CoPAT to relieve clinic pressures and support the clinics as well as support safe antibiotic administration in the community. Virtual model of care. The virtual nature of CoPAT also allowed patients to remain at home, avoiding unnecessary hospital exposure and providing a clinic model more convenient for patients, especially for those in rural and remote regions, which was ideal during COVID. So we demonstrated that our CoPAT model has potential cost benefit. Our CoPAT cohort potentially saved over 300 days of IV treatment, mitigating the financial costs and risks associated with IV therapy. And we've, likely underestimated the direct cost savings as we didn't take into account costs saved from ED presentations or those associated with prevention of line-related complications. Other caveats to our, maybe it'll work now. So other caveats to our, there we go. Other caveats to our cost analysis was that we capped our patient capacity to 30 for the pilot, and everyone received weekly reviews as it was a proof of concept study. But with greater experience, we realised that moving forward, the service model could be adjusted to move patients onto less frequent monitoring once they were stabilised on therapy, and also patients who had lower disease burden and patient risk factors could have lower monitoring. So in the broader context, there's potential to increase service capacity and cost benefit with remodelling, and we're currently working on defining these protocol adjustments moving forward. So future work includes broader economic evaluation to realise the full cost benefit of the service and optimise the clinic for cost effectiveness. And finally, the benefits of CoPAT are far-reaching. With a virtual model of care, removing the traditional geographical boundaries to service delivery, CoPAT can provide equitable care to patients across the district, including rural and remote regions. So that was a bit of a stumble towards the end, but I'd like to finish off by acknowledging some of the key people involved in the study. So Associate Professor Kate McCarthy, our medical lead, Tia Stewart and Sam, the clinical nurses for the project, Kerry Kinsella, Andy Hale, and Dr. Michael Holtz.
All right, thank you. That was really fantastic, very interesting.